Opioid addiction is a national public health crisis that affects individuals and families regardless of their age, race, or income. The statistics are overwhelming. More than 130 people die from opioid addiction every day. But there is hope. Recovery is possible. The information contained in these podcasts is solely for informational purposes and should not replace advice from a medical provider when making healthcare decisions. This podcast contains opinionated content and may not reflect the opinions of any organization this podcast is affiliated with. We will discuss opioid use and opioid treatment, which may be triggering for some listeners. Listener discretion is advised.
In Season 3, we'll be exploring the meaning of inclusive recovery. Today, on Someone You Know, we're joined by Dr. Jean Marie Perrone. Dr. Perrone is a double board certified physician who works as a professor in the Department of Emergency Medicine at the Hospital of the University of Pennsylvania, is the director of the Division of Medical Toxicology and Addiction Medicine Initiatives, and the director of the Penn Medicine Center for Addiction Medicine and Policy, as well as a successful published research author. On this episode, we discuss Dr. Perrone's role as a national leader in her efforts to address the opioid epidemic, equitable access to care, spearheading Penn's CareConnect warmline, the stigma around using lifesaving medications to treat substance use disorder, and Dr. Perrone's hope for the larger impact of her work. I'm your host, Heather Major, and this is Someone You Know. You've been at this work for many years. I won't date you, but your bio, takes it back a couple of decades at this point. And first, I wanted to just understand a little bit more about why you went into this field of medicine. Obviously, in today's world, we're talking a lot more about substance use disorder and addiction medicine. What was it like when you started, and what was some of your thinking going into this field?
Yeah, it's been quite an evolution. It's a really good question. I actually did an emergency medicine residency at Thomas Jefferson in Philadelphia. I was really interested in the concept that emergency physicians treat everyone who walks through the door, regardless of insurance or other status, and we treat people in the order of the acuity of their disease. So it's not like other places where people make appointments and there's insurance prerequisites. So I love that about emergency medicine. I love that we could take care of a variety of diseases across the age spectrum. After my emergency medicine residency, I did a 2-year fellowship in medical toxicology at Bellevue in New York. And that was really studying poisonings and overdoses, but not just substance use. It was people who, had depression and tried to overdose on pills. And fortunately, in that era, a lot of medications got safer and people were doing better because we were actively making policies to prevent poisonings and overdoses in children by having safe packaging and a lot of other strategies. So that when I started my actual career in emergency medicine and medical toxicology at Penn, poisonings were less common for the first 5 or 10 years, or serious poisonings were. But then we started seeing this new subset of people, which was people who had become dependent on opioids because of pain medication. And what we really saw in that era was a lot of liberalization of opioid prescribing that was supported and promoted by various sort of misguided incentives around treating pain. It was a nice concept to treat pain aggressively, but that did not mean or should not have meant everyone gets opioids. And so that fueled a lot of interest in opioids. It fueled a lot of overflow and opioids that got into teenagers and other places. And so that's when I became aware that we should change prescribing. And I started trying to teach clinicians and colleagues that, really, for young people with, sprains and strains, they should get, ibuprofen instead of, oxycodone. So from that work, over a few more years, it evolved into picking up the pieces of the patients who now had opioid dependence and opioid addiction. And that's when I started doing addiction medicine care. So it's been an evolution and a lot of observations made in the clinical environment of where the needs were and who was being left behind and who was being harmed by some of our practices.
With the longevity of your clinical experience in substance use disorder addiction medicine. What drives you, what motivates you to keep engaged? And maybe it's in part, that you are an emergency medicine physician, still obviously practicing. What's kept you engaged?
Yeah, I mean, I think it's many different things. I think it's the clinical environment, like you said, the stories and the engagement we get from patients who find out for the first time that there is treatment and that they don't have to jump through hoops to get started on a medication. So that's really satisfying. And I work with the most amazing team of people who are both in recovery or have gone into this work because they've suffered with a family member who struggled. And they're just, really wonderful harm reduction advocates. So we have an amazing team at the Center for Addiction Medicine and Policy. And honestly, it's the circle that they have brought in with patients and success stories that just makes it so satisfying. So, not every day is a success story, but there's always something every single week where, we can just be touched by a barrier that someone was able to overcome, or, one step in the right direction. And it's just really fulfilling.
I think that really does speak to also the issue of stigma. What does that look like, the stigma of addiction in emergency medicine? You were saying, emergency medicine was attractive to you because it's all people. You're going to see many disease states. You're going to see people at various stages of need. What does stigma look like to you?
Yeah, I mean, I think that we've evolved a lot in the emergency department, but in the early days, stigma looked like people calling patients, the word drug addict, that's just a drug addict coming in for a fix. And they would apply that to people who had opioid use disorder, or people who were coming in who had pain problems and, were coming in asking for pain medication because their, chronic disease had them dependent on opioids. So we did a lot to reframe the challenges that patients face. We did a lot. I really give a lot of credit to a nurse that I've been working with for about 10 years, Rachel McFadden, who came and just came along as a partner. She was a student, I think, when I first met her, but her work has really been to reshape the language around treating patients. And she's just an admirable character, and the way she presents herself in the emergency department is really one that her colleagues want to emulate. So seeing her being respectful and kind to patients, and the rapport that she can get to a patient. I mean, patients are afraid and they're scared and they feel sick, and she treats them with compassion and blankets and really love, and they they turn around and they give her that love right back, and her colleagues see that. And I think that's just been a model for we're all in this together. We shouldn't be at adversarial positions. We should be trying to help everybody equally. So it's evolved a lot, but I think that we have a lot of advocates now on our nurse and clinician teams that we didn't have before.
That's great to hear. And we've been in a tremendous backslide in terms of where we are today compared to 2-3 years ago in overdose deaths. Back in 2020, there was a stat about 25% increase across 25 emergency departments for opioid overdose rates, not death rates, but just the rates of overdose from opioids. What are you seeing today?
We are still seeing a lot of missed opportunities. There are, as statistics, 104,000 people died of overdoses last year. And that really is being attributed to the potency, lethality, and ubiquity of fentanyl in the drug supply. So we're seeing fentanyl in cocaine, we're seeing fentanyl in methamphetamine, and we're just seeing, I think, fentanyl really being inexpensive and widely available. So it's almost like that oxycodone 15 years ago was easy to find on the street. Now, people who maybe aren't looking for, that kind of potent substance, but it's just there. People are getting exposed when they didn't ever intend to be in that route. So we're seeing more overdoses in people who don't use opioids. So, people who are using cocaine historically and an opioid gets into their cocaine supply, they're opioid naive, so they don't have tolerance and they just have an overdose. So that's where Narcan comes in. We've really tried to saturate our community with Narcan, and I think we know that is effective, but it's being outpaced by the potency of fentanyl. So there's a lot of work to do there. We know that buprenorphine or Suboxone treatment protects against opioid overdose, but people don't have wide awareness of that. And so there's a lot of opportunities for education, and then just what we call low barrier care, getting people into treatment without 30 days of agreeing to go away, or we just need to start treatment the same day people want to get started.
Maybe we could talk a little bit more about that, because you've been at the forefront nationally and certainly here in the Philadelphia region of a lot of that work. Do you want to talk a little bit about whether it's the research side or the program side of things that are happening that you're involved in to increase those early initiation rates for individuals?
Yeah, I sure would. About 4 or 5 years ago, we started kind of educating our colleagues, and it was, like I said, a little bit of a kind of next step from changing our opioid prescribing to adding buprenorphine or Suboxone to the skill set of emergency physicians to be able to start somebody who came into the emergency department sick and withdrawal. I can remember a young girl who took an ambulance to the hospital a couple of years ago who had tried to quit on her own. She had started using oxycodone from her family member. I think actually originally it was prescribed to her, and then when her prescription ran out, she just started using another family member's. And over the course of 6 months to a year, she'd had multiple episodes where she went out of her way to get opioids or was buying opioids on the street, and now realized that what she was buying was actually not oxycodone anymore, but pressed fentanyl tablets. And that really terrified her. So she had quit about 48 hours before she came to the hospital, but she was having so much profound nausea and vomiting and was just so sick that she called an ambulance. And we were in the emergency department that day, and we just said, look, we have something for you. We have something that will stop the vomiting, will make you feel better. You can start it right now, and we're going to give it to you in half an hour. Are you okay with that? And she said, oh my God, I didn't know that there was a possibility. And we gave her 1 dose of Suboxone, and she just felt okay. She wasn't intoxicated. She just felt normal, as she said. And she was so relieved and so grateful. And just that reversal of, being a 10 out of 10 of misery to just being normal is a gift. And people don't know, families don't know that there is a treatment that can mitigate the symptoms of withdrawal and get you, off of these, highly lethal fentanyl and other opioid compounds.
And we often, I think, assume that patients will know how to advocate for themselves, or there's a mistrust with medical profession. And of course, right, if you prescribe me an opioid, and now you want to put me on a different medication, what does that look like in your world? Because there's got to be a mix of very different attitudes and perceptions, even among colleagues, but also among patients.
Yeah. So, I mean, before, that patient scenario, we would have a patient like that come in, and she would get treated with a variety of medicines to make her feel less miserable, none of which would work completely. So, it became more of a possibility that emergency physicians could actually start writing prescriptions for Suboxone. So about around that same era, 5 years ago, there was a lot of, there's a lot of regulations around opioid prescribing that goes back to the 1920s. But in order to prescribe Suboxone, you actually need to take an 8-hour course. And that's a big commitment for clinicians. So, around that time, a few years ago, we actually tried to get all of our emergency physicians to take that course. And that was a big hurdle. But we did it over a 6-week period. Everyone took the course. So 100% of our prescribers and providers were able to treat anyone. we started a program through all of our downtown emergency departments where people could come in and we could start their first prescription or start their first dose of medication in the ED, and then hand them off to our primary care providers who had also taken that course and who were basically integrating addiction care into primary care. So these patients would have high blood pressure and heart disease, but they also had opioid addiction, but they didn't have to go to a different clinic for their opioid addiction. You know, addiction is a chronic relapsing disease of the brain, just like diabetes is a chronic relapsing disease of the pancreas. And so, you know, equating those two as a medical problem, you know, validates the patient's huge challenges and life-threatening risk from this disease with, you know, you're entitled to see a doctor for this and be treated just like you are for your hypertension and diabetes. So having that paradigm in the ED and being able to hand off to our primary care providers has created this network of clinicians who are committed and able to do something. You know, it's terrible to watch this disease and, you know, say there's nothing I have to offer. Conversely, it feels so satisfying to be able to offer something and watch people get into recovery. I know for my primary care colleagues, they often tell stories of, you know, when they told their practices that they wanted to do this, there was a little bit of pushback. And now that those same people who created the pushback in the office setting are the ones who bring in the birthday cake for the, you know, woman who celebrates a year of recovery and coming to the office. And so, you know, it's a wonderful thing to participate in the joys of recovery and patients' new lives and getting back to work and family in a successful way.
That's incredible. I do want to keep going with things that you're involved in. We could literally talk all day about things that you're involved in, but CareConnect, is it something we could talk about and have you share a little bit more about?
Yeah. So really in the pandemic, we had this great program of people, you know, coming to the ED, starting care, but, you know, people weren't coming to the ED during the pandemic. And patients would be calling our recovery specialists and say, you know, I need a refill of my Suboxone, or, you know, I dropped out of care, but now I want to get back into care, but I can't go to the ER because I'm terrified. And so we started, you know, in March and April of 2020, the DEA and other organizations changed the regulations around prescribing buprenorphine. There used to be a requirement that you had to have an in-person face-to-face visit in order to do that. And because of the pandemic, that was waived to allow telephone and audiovisual telehealth. So we really started doing that in sort of spontaneously. It was a little bit of a challenge because we had to make a patient encounter. We didn't have a medical record. There wasn't anyone set to do this. So we did a lot of improvisation, but what we learned was that the patients loved it. They didn't have to come to the ED and wait, even as much as we were proud of what we were able to do. It's not the, you know, most friendly environment. It's an expensive environment. So we were able to shift that through support from the Philadelphia Department of Public Health. We created the CareConnect warmline, which is a substance use navigation portal so that patients can call. Their first call is answered by a substance use navigator who either has personal or family experience with people with substance use challenges, and they navigate them. You know, are you someone who you think you want methadone? Here's what we can offer you in terms of, you know, buprenorphine. We can get you started today. If that seems like a good option for the patient, they then connect them with an appointment with our Penn Medicine on Demand, which is our Penn virtual urgent care. And the providers there have been trained in buprenorphine prescribing. So they're a wonderful group of nurse practitioners who will then meet with the patient officially, either by phone or by audiovisual telehealth, and start their prescription, e-prescribed to a pharmacy. And we can support the patient getting to the pharmacy and then starting that recovery journey. We also make appointments back to our primary care. So it's really an adjunct to the emergency department and allowing patients to get care in a patient-centered way. It's a lot less expensive. It's a lot more favorable in terms of the barriers that patients have: transportation barriers, childcare barriers, appointment making barriers. You know, they have a treatable moment and they can have treatment within a few hours. That's really the goal of mitigating the harms of opioid use disorder by having a low barrier treatment option.
I think it's incredible. And I think it really does demonstrate when you can start to meet people where they are and really get not only get them in that moment, but make sure that the types of resources the patient needs are available to them. Like you said, low barrier. When we talk about addiction and the history of addiction in our country and where we are today, I wanted to just get your thoughts on equity and equitable access to treatment and recovery supports, and what you're seeing as an emergency physician throughout your career.
Yeah, I think, as the importance of looking at equity across almost all treatments, we're seeing huge gaps. I think you could look at high blood pressure care, you could look at, cardiac care. Unfortunately, as we probe into addiction care, those same inequities exist. Patients who have opioid overdoses have a very low rate of getting into treatment in the next 30 days, regardless of color. But when you break it down by race and ethnicity, the patients who are white do have double the rate of people who are essentially non-white. So we know that there are inequities. We're not sure if those are insurance-based, because sometimes when you stratify by insurance, the inequities exist. So we're looking at other challenges. Is it because people are not aware of treatment options, or are they not interested in taking a medication for this problem? Is it because of religious reasons? So there's really quite a lot of work to be done to explore why the gap exists. We are doing a lot of efforts in some of our communities around our downtown hospitals to try and identify what factors people would be more comfortable exploring. Because whether you look at methadone or buprenorphine or other inpatient treatments, there has been this equity gap across all of them. And unfortunately, abstinence is a very challenging route to be successful. Abstinence is the basis of Alcoholics Anonymous, and a lot of alcohol treatment, which is probably the thing that everybody has a lot of family and other familiarity with. Somebody who's struggling goes away for 30 days and then they come back and they go to meetings, and the whole paradigm is to stop drinking, get rid of all the alcohol in the house, get rid of everyone who may influence somebody to start drinking again. With opioid use disorder, the treatment, it really, the successful treatments, either buprenorphine or methadone, really require a patient to take a medication, and that medication reduces their risk of overdose death by 60%. So having this dramatic evidence basis for medications is hard to translate to the public, because people really love this idea of, I paid to have my son go away for 30 days. He came back, we watched him really closely, and he did great. That's not the way the story goes, unfortunately, because the cravings and the change in the brain that occurs, the neurochemistry, is really doesn't get fixed in 30 days. And so those cravings, they will, they will recur, and we know they will recur. And that patient who now hasn't had opioids for 30 days is even more vulnerable to fatal overdose. And the fact that they need to hide their use so dramatically leads to, people running off, getting opioids, hiding somewhere, and then, unfortunately having a fatal or non-fatal overdose in an area where they're, fearing being, found out again. So it's a bad cycle. And I think a lot of education around why medications are important is really probably the biggest stigma we need to overcome, because clinicians have it too. Clinicians think that we're substituting one medication for another, and we need to really overcome that with the evidence.
I think that is a great segue into what, again, your work. I wanted to make sure we had a minute to talk about the Center for Addiction Medicine and Policy that you are founder of. Can you share a little bit more about the focus of the center and what the objectives and goals are of that work?
Yeah, I can. I think Penn is a powerhouse of research and clinical care, particularly cancer care, transplant care, primary care. But when it came to addiction care, our focus was a lot more on research and a little less on clinical opportunities. I often told people that if your 20-year-old son was diagnosed with, Hodgkin's lymphoma, that you would look at our website and you wouldn't know which amazing expert to try to get an appointment with. But if your son was diagnosed with opioid use disorder at 20, which was probably 10 times more fatal than Hodgkin's disease at this point, you wouldn't be able to find a clinician, or as of a few years ago, who specialized in that. So we really wanted to bring the power of Penn's clinical research and education, expertise, to integrating that across all the departments that were doing little bits of work. So primary care medicine, internal medicine, family medicine, emergency medicine, and psychiatry all together had a little piece of this, but we really needed to integrate across those because there is no department of addiction medicine. And so we're really still working together to create, more educational opportunities in the medical school and more clinical opportunities for students to shadow us in the emergency department or shadow us in primary care doing this work, and elevate this field of addiction medicine, which is relatively new compared to cancer care or other things that we do, and really make it a top priority, given that it is, the cause of so much mortality in our city.
Absolutely. I mean, it's the work that you do, and I know that you and you're part of these amazing teams as well. It is so incredible. You kind of alluded to this earlier. It's not always a happy ending. There's not always, those are the most satisfying when you have the happier stories. But you want to have impact in your work, right? It's why you became a doctor. What's the kind of impact that you want your work to have, either locally or nationally?
It would be wonderful in Philadelphia to be able to track, there's this graph that I show about buprenorphine in Baltimore. So the evidence that medications work, and when they had a heroin escalation in the 90s, they basically opened more methadone clinics, they got more buprenorphine prescribers, and they watched the death rates go down just because treatment access expanded. I would love to see that turnaround in Philadelphia, and it's possible. We are making great strides in access, but we do need to expand a little bit more. We need to get more health centers and primary care practices comfortable with this, and it's a big shift. It's hard to teach busy clinicians to do something new, and I think telehealth has been a wonderful strategy, and I think our model with the CareConnect warmline is growing, and hopefully we're going to be able to work with the state to grow it, more in like rural areas that don't have access. But I would love to see the turnaround in Philadelphia that could be correlated with more medications and more easy access treatment opportunities, and that's possible both in a data analytics. We have ways of tracking this data, and also in just treatment access. I think more younger clinicians are getting this training in school. We are actually starting an addiction medicine fellowship at Penn, which has been also a long-term goal of ours that we're going to start in July. So creating the pipeline of more clinicians, because at this point we have a handful of literally 5 people who are addiction medicine boarded, and we probably need 100 for our health system. So growing that pipeline, and also creating the treatment opportunities with low barriers for people to just walk in and get care, or pick up the phone and get care. I think that's really where we're going in the future, and it can make that turnaround impact.
I think that gives us, as you know, the IBC Foundation has been committed to this work for a number of years now, and it's part of how our paths connected and crossed, and hopefully continue to get to work with you on all of the great work that you're doing today, and certainly on the strategies that you have in mind for the future. And I could spend way more time than you have talking about some of your more recent endeavors with hearings, et cetera. But I'm just really appreciative of you making the time for us and our listeners to hear from you today. And I think that you have given an incredible perspective from someone who's been in the field longer than a lot of mainstream narrative has been around. And it's important, and it's important that that we keep supporting you as a leader in this space. So
thank you. I would love to thank the foundation. A couple of years, well, 3 or 4 years ago, you supported one of our first pilot studies in getting clinicians ex-waivered. And as I mentioned, there was this whole 8-hour requirement that clinicians had to take in order to get comfortable. And we thought that if we gave people a 20-minute version of it, they could feel comfortable prescribing buprenorphine or administering buprenorphine in the emergency department. And that study actually did demonstrate in 110 or so clinicians that if you gave them the short version, they get the idea enough. And we found that a third of the patients that got the short version actually were able to give buprenorphine in the emergency department. And that's actually even more pivotal now that the 8-hour training is not required for emergency physicians. But what we're finding is people still want a short version of how to do this. So we're still relying on those training work that we did, that you supported. And hopefully that will continue to be a strategy for the quick fix and make this really part of everyone's early education on addiction treatment that is becoming part of medical school basic science education. So I thank you for your support.
Well, we appreciate the opportunity always to collaborate, and I look forward to our continued conversations, not on this podcast, of course, but our continued conversations around ways we can keep moving that needle and again, getting to a place that you are very confident that we could be as a city and as a region in terms of getting folks into treatment. So thank you again so much.
Sure. I hope we can talk again in 2 years and look at that graph together.
I hope so too, and I hope we can be even more connected on how to get there.
Thank you. That's a great vision.
Thanks, Dr. Perrone. It's great seeing you.
You too. Thank you for your time.
If you or someone you know is suffering from opioid addiction, please visit ibxfoundation.org/SYK. The link is in our show notes below.